Hi, my name is Kira Smith. I am doing scenario number one for this example. So Mr. O is 63 years old. He was dizzy and lightheaded at home and almost fell. His wife brought him by car to the ER. Mr. O was admitted to the AMU with syncope. This is not the first time this patient was brought to the hospital. He has been treated in the past for congestive heart failure and acute myocardial infarction. He feels like he is pretty healthy as he only takes NSAIDs at home for chronic back pain. Mr. O got to the AMU at 1600. His name is, or nurse's name is Jenny. RN Jenny assessed him and found his blood pressure 138 over 84, pulse 76 and regular, his respiratory rate 16, his AFib at 98.6. Mr. O's labs were normal, but his IV infiltration during transport. So Jenny, the RN, started a new IV and put a warm compress on the old site. Jenny, RN, reported off to Ben, RN, at 1900. At 2130, the PCA found Ben, RN, and told him that he had just helped Mr. O off the bedpan. Mr. O had a large black tarry stool and was complaining of not feeling well. Ben, RN, went into assessing Mr. O. His vital signs were blood pressure 94 over 66, pulse 114, and respiration rate 24. His pulse ox was 87. He was pale. His skin was clammy. Ben, the RN, asked him how he was feeling. Mr. O said he just didn't feel well and could not get comfortable. He asked if he could have something for his belly. It was really hurting him. Ben, the RN, asked his abdomen and found that it was distended, and Mr. O had diffused abdominal pain. He rated the pain a 6 on a scale of 1 to 10. So the S-bar example with the situation would be the nurse calling the physician to report to the AM unit floor. So as a nurse, hi, Dr. Shepard, this is RN Kira Smith in room 1 at the AM unit. I have patient Mr. O. He's 63 years old. PCA found me at 2130 after helping Mr. O off the bedpan. The PCA had noticed a large black tarry stool and mentioned patient was complaining that he didn't feel well and his belly is really hurting him. The background for the B part of the scenario would be stating that the patient was brought by his wife by car to the ER and was admitted to the AMU at 1600 on July 5th with syncope. His vital read blood pressure of 138 over 84, pulse 76, and regular respiration rate of 16. His AFib at 98.6. His labs were normal. His IV infiltrated during transportation, so the nurse started him on a new one and put a warm compress in the old site. Past medical history is that he was treated in the past for congestive heart failure and acute myocardial infarction. Patient is pretty healthy, no known allergies, and only takes NSAIDs at home for chronic back pain. It's been over 5.5 hours, and the patient had his blood pressure, it dropped at 94 over 66, increased in pulse to 114 with an increased respiration rate of 24. His pulse ox was 97, patient appears pale in color, and his skin was clammy. He does complain of abdominal pain, which is a 6 out of 10. The R would be for recommendations, and that portion would be, as a nurse, the patient has been given fluids. We are going to continue to monitor the heart rate and blood pressure. The desired outcome is to control and stop bleeding, to return vital signs to normal and receive normal blood counts and hemoglobin levels. Mr. O needs to be seen by a physician now if you can come down and evaluate his condition. And then as he comes down, then we can ask for the physician for a recommendation. So, is this considered a medical situation? We increase fluids. The should we watch for the causes of heart failure? Do we need a GI consult and from a doctor? Do we need the patient at NPO? Since the patient was on NSAIDs, do we need him to stop that because it's probably contributing to his GI bleeds? And in that case, do we need a GI doctor to come down and look? And then the patient also would need blood, so we would need consent from the doctor as well. If we can go ahead and do that, do I have your permission? And then the physician would approve all that, but also I have noted too he would say a new order is needed. Please monitor fluids, blood pressure, pulse, respiratory rate. Labs need to be done to assess the blood count, to evaluate the hemoglobin levels. We'll assess for the possible blood transfusion. If hemoglobin levels are below 8, give a proxenic to reduce ulceration, which could be causing GI bleed, and then potentially surgical intervention may be needed to stop the bleeding. So the discussion points, thoughts on the scenario. So NSAIDs used for chronic back pain. Adverse reactions for NSAIDs are heartburn, severe GI bleeding and GI pain, acute renal failure, increased risk for MIs and stroke, hepatotoxicity, altered hemostasis, non-cardiogenic pulmonary edema, and the nursing care plans for GI bleeding. The scenario mentioned the patient needing help getting off the bedpan and wasn't feeling well. Also, dizziness, weakness, abdominal pain are subjective data, while the pale skin and hypotension are objective data that are strong indications for GI bleeding. The black tarry stool is connected to upper GI bleeding, while lower GI bleeding is bright red bleeding usually. Therefore, the location of the GI bleeding is known in this case. 97% is decent for oxygen saturation. However, the blood pressure, pulse, and heart rate are extreme levels, which are concerning. And I think every point in the SBAR is important. You can't have too much information. It's helpful to keep things consistent for the physician and the nurse too, and especially in situations that are intense and emergencies, to know what information is needed. Even if it isn't used every time, it's good to have more information than not. I also believe this is significant for the situation and was clearly presented to the physician. And that is it. Thank you so much.